Welcome everyone to today's Ask the Expert session. I'm Lori Shogren. I'm the Community Services Director here at the National Ataxia Foundation, and I will be assisting with today's webinar along with a few of my colleagues. Now, I am excited, as always, to welcome back our resident expert, Dr. Susan Perlman. Dr. Perlman is a clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Thank you so much for inviting me back. I look forward to the questions. I learn many things from the questions. Any question that I'm not sure about or can't answer, I know Lori is going to keep track of, and I promise to try to get back to her with, updates on some of the answers that I don't have at my fingertips right now. Again, I'm not happy to see so many people with ataxia, but I am encouraged that we can exchange ideas and I may have answers to some of the questions and that we can hopefully learn together. So here's the first question is about troriluzole. And I see that, there's an additional question that has been brought up, and this is important because troriluzole has been under examination for the treatment of the dominantly inherited ataxias, spinocerebellar ataxia, for over 6 years. It was developed as a prodrug that turns into riluzole, which has been around for many years for the treatment of Lou Gehrig's disease. It was felt to be neuroprotective, and in 2 European studies, upwards of maybe almost 10 years ago, was hoping to show some neuroprotection for ataxia, but surprisingly showed some symptomatic improvement and possible slowing of progression as well. So the company Biohaven has put together some extensive additional data analysis under the supervision of the FDA, and they feel they're at a point where they can actually submit for approval by the FDA to license it in the United States. Many patients are taking regular riluzole, troriluzole, easier to take, fewer side effects, and may have a better symptomatic benefit. So question, will it come to market in Europe as well? I think our experience with the only other approved drug for ataxia, omaveloxolone or Skyclarys for Friedreich's, is that it was approved over a year ago by the FDA in the United States, and only within the last few months did it get approval in the European Union. Still not approved in England, in Canada, in Australia, in New Zealand. Their own regulatory agencies are looking over the data, and I'm concerned and probably expect that should we get approval in the United States, approval in other markets around the world will come, but it will probably be delayed. In the US, I have many patients who are taking regular riluzole. It's available off-label, and with discount coupons, you can get it for less than $40 a month. But again, troriluzole hopefully will be specifically approved for spinocerebellar ataxia. So we will wait and see. Next question from Chris. 75 years old, diagnosed with spinocerebellar ataxia type 3, inherited from mom. Progression, obviously, with another family member, you're going to be aware of it, and then aware of your own symptoms. Concerns about, being careful about, swallowing. We know that in the ataxias, the 2 primary causes of disability and death are falls with injuries and swallowing problems with choking. So if you're going to follow any 2 performance measures, falls, fall risk, and swallowing issues. Often a swallow test is performed to get a sense of your baseline. This individual, Chris, has had coughing fits, on crumbs or a drop of water or even thin air. That probably is a sign of incoordination of the swallowing muscles. May be a sign of an increased cough reflex, which is a good thing, means you can cough stuff and it won't end up in your lungs. And that is the concern. People whose cough isn't as vigorous may have, sneaky bits of liquid or food ending up in their lungs, causing pneumonia, which could be, life-threatening. So usually if you notice some difficulties with coughing, choking, eating, drinking, to consult with a speech therapist, have a swallow study done, and then get recommendations how to control that. It may, be changing, the kinds of foods you eat. It may be changing the way you drink. But there's always something that could be done. And it's important, as you point out, Chris, to really be aware of that. Now, here's a question from Jonas. His girlfriend has AOA2, and a professor in Tübingen in Germany mentioned that it could take 3 to 4 years before there might be a study available in Germany. There is intensive research going on with the mechanism of AOA2, ataxia with oculomotor apraxia type 2, which is one of the common causes of ataxia in the late teenage years. Friedreich's tends to be an earlier problem. So 2 questions there. Very interested in potential therapeutic approaches, especially troriluzole, which, as he points out, could slow progression. Would this be a viable option for other cerebellar disorders besides spinocerebellar ataxia? That is a good question. I had the same question a few years back when we were enrolling people in the Biohaven study, but some people didn't have the right ataxia. They failed enrollment for other reasons, and I thought, they deserved to try troriluzole. So I started a medium-sized investigator-initiated study of troriluzole in people who didn't qualify for the Biohaven trial. Half of them had genetic ataxia of other types, half had non-genetic ataxia. And the non-genetic ataxias didn't respond as well. The other genetic ataxias did seem to have a response. So I would say any disorder that affects the cerebellum, and potentially even static disorders, a head injury that affected the cerebellum or a stroke, could be improved by troriluzole, either symptomatically, and for a condition that's felt to be progressive like AOA2, could have the opportunity to slow progression from its neuroprotective effects. And then curiosity about the possibility of messenger RNA therapies. Do I believe that such a therapy could be relevant? Any genetic disorder, could have a DNA or RNA-directed therapy to block the production of an abnormal protein or protect the gene so that it can make relatively normal levels of protein. Now, AOA2 is a deficiency syndrome. There's, synataxin, which is not being made at proper levels. The amount that does get made is normal, it's functional, but it's too low. So you can do messenger RNA-directed therapies that will improve the production of the protein in various ways. It might enable you on, a defective gene to make a modified protein that still functions. It might enable you to make, a messenger RNA that makes a protein that lasts longer and doesn't get broken down as quickly. So there are a lot of strategies to deal with either replacing the missing protein or making the DNA and RNA behave in a way that allows it to, be present at higher levels and more functional levels. You apparently have heard about a boy who received therapy in Boston. I'm not familiar with that, but apparently the therapy is continuing. So let me see if I can do a little research in messenger RNA therapies for AOA2 Boston, and then I will make sure that that Lori gets back to you. And I'm just going to write down your name here so I can remind Lori, who asked this very, very good question. Now, next question. Again, a question about troriluzole and riluzole. Do I think the effect wears off over time? we know that troriluzole and the regular riluzole are not cures. They stimulate Purkinje cells to work better and protect Purkinje cells from excitotoxicity, which can cause death of those very important cells in the cerebellum. So that behind the scenes, the gene mutation is still operating. So that over time, there will be Purkinje cells that, because of the genetic mutation, in those cases, the Purkinje cells die. And, the effects of riluzole or troriluzole will have fewer things to act on. So I think a concern that we all have, and I think a good parallel is Parkinson's disease, where, the first drug that was so dramatically helpful, carbidopa, levodopa, was found early on to work great for 5 years or so, and then the effects, the benefits were declining. So now it's recommended, in Parkinson's, that carbidopa, levodopa be started later, so that you can get those good 5 years of response, at a more important time of the disease. So I think you're right. Once we get a longer term look at people using off-label regular riluzole or hopefully approved troriluzole in the real world, we'll have a sense of, the amount of benefit, the amount of slowing of disease progression, and also how long those benefits stay. Until we have better treatments available that may be directed to the gene, this, could be a very important bridging drug for people to be able to try. Now, Tatiana, 64, has a late onset cerebellar ataxia and is taking 200 milligrams of CoQ10 daily. Would like to take more. So one thing we know about CoQ10 is that it does get into the brain, it does get into the mitochondria, but taking more than 1,200 milligrams per day is not going to get any more into the brain where it needs to. So 200 milligrams is the minimum amount that in normal circumstances your body would need to conduct most of its activities in the mitochondria and energy production. So by adding an additional 200 milligrams to what your body is already making, you're giving it a little boost. If you want to take more, I think you could go up to as much as 1,200. Many people take 600. So you can go up stepwise and see how you feel. Some of the benefits people have reported, improved energy levels. Whether it actually can alter disease progression, not really clear at this point. It's an important cofactor, but it's a relatively mild one. And you're right, there have been studies, showing that, it could in a test tube and in animal models have benefits. But you're right, there could be long-term side effects. I'm not aware of CoQ10 being a cancer risk or a tumor risk supplement. So I'm going to check on that as well, just to see what they're talking about. Oh, and I see you have some references there. So hopefully I'm going to get Lori to, well, I can probably copy and paste them out as well. So let me do that. And then I can look at the references and see if I can get any more information out of them. So our discussion today is, tending to the way it often goes in my clinic, where somebody will come up with a good question, and then we'll look it up together online, or I'll do a little more research and get back to them. Can I explain the effects of glutamate and GABA on spinocerebellar ataxia? Is there anything you can do naturally to promote in the absence of approved medications? I don't know about natural substances to help alter GAD or GABA levels, and I'm sure they're out there. But glutamate is the primary neurotransmitter for stimulating Purkinje cells. And Purkinje cells are the primary cells in the cerebellum that determine how active it's going to be, how effective it's going to be at controlling coordination and tremor. So that if glutamate is reduced, if the ability of glutamate to stimulate Purkinje cells, because Purkinje cells have been damaged by a genetic factor, then, obviously glutamate signaling is going to be compromised. On the other hand, if there's too much glutamate, it can overstimulate Purkinje cells and lead to increased stress on those cells. So I'm going to look into what's available on the natural healing side for glutamate and GABA, and I will get back to you. Now, Mary is taking dalfampridine, a potassium channel blocker, with good results. And this, has its impact on the potassium channels that, together with calcium channels, determine how much electrical stability the Purkinje cells will have. So dalfampridine is a stabilizer, restoring better balance between, the potassium, sodium to some extent, and calcium channels that provide the electrical balance for our cerebellum. And it can be very helpful for dizziness. It can be helpful for ataxia. It can be helpful for episodic ataxia in stabilizing those pathways. Doesn't work for everybody, but has pretty few side effects. Since bodies need a fair amount of potassium, is this just blocking potassium to our nerves or to all cells? Now, one of the side effects of too much dalfampridine is seizures. And we know seizures are triggered by usually instability in, the electrical pathways controlled by the sodium-potassium balance. So potassium in other parts of the body is probably not significantly affected, but certainly the potassium-sodium balance regarding electrical activity in the brain could be compromised by too much dalfampridine. So it's, typically the side effects are not going to affect skeletal muscle or other cells. Now, another question about troriluzole, which I think I answered for less common forms of SCA. And I think the question here, certainly the trials that have been done in Europe with regular riluzole included a variety of cerebellar ataxias, not just SCA. Here it was restricted to SCA 1, 2, 3, 6, 7, 8, and 10. So if the FDA gives approval to troriluzole, if it gives a general approval for spinocerebellar ataxia, it could potentially be tried with anybody with a spinocerebellar ataxia diagnosis. If they're restrictive to just the SCAs that were part of the studies, that is going to be limiting. Not so much that you couldn't get your doctor to prescribe it, but getting your insurance company to pay for it, could be a roadblock if for some reason you don't meet the criteria set out by the FDA. So how is the effect of troriluzole on SCA6 patients in Biohaven's trial? Now, the statistical analysis in the first study and the second study and the open label study that's going on by Biohaven, the types of ataxia that had the most people enrolled, which was SCA3 because that's the most common ataxia, when you look at the statistics, the more numbers you have, the better the statistics will be. So on an individual basis, individual patients with SCA6 in the study probably did have improvement in symptoms. It would be harder to measure slowing of progression because SCA6 changes so slowly over time, but certainly the mechanism of SCA6 Purkinje cell dysfunction could have and probably did have a response to troriluzole, but the numbers were small enough that it probably didn't show up in a statistically meaningful way, although I know that Biohaven did do additional statistical analyses which haven't been published yet, and they may be able to give us some numbers of the impact on the SCA6 population. Have I had any patients who have had a cerebellar stroke and in addition have SCA6? I have had patients with spinocerebellar ataxia who have had some other insult. They've had a stroke that may have impacted the brain or the cerebellum. They've had normal pressure hydrocephalus, which can alter connections from the cerebellum to the brain and the spinal cord. So, having a genetic ataxia doesn't make you immune from other conditions. And the addition of another problem from a stroke or normal pressure hydrocephalus or brain inflammation Anybody could get a meningitis or an encephalitis on a viral basis. Like I say, you're not immune, is going to amplify the symptoms. But if it doesn't leave permanent damage, it won't cause the symptoms to progress more rapidly. On the other hand, if you have a cerebellar stroke on top of SCA6, it takes away reserve. So your performance will be down, and you probably won't recover 100% back to your baseline. But the things that can speed up progression of symptoms are things that are more generally impacting. Head injury can do it. Multiple exposures to general anesthesia in a short period of time can do it. So these are things that could potentially seem to accelerate progression of symptoms. But you deal with things as they come up. Many of the concerns about stroke, they have good rehab programs. So take advantage of what medicine can offer on the other side besides our genetic diagnoses. Carol has a question. If most of the drugs for ataxia are through oxidation, will antioxidants help? We know that with gene stress from a gene that is producing an abnormal protein or a gene that is underproducing protein and depriving nerve cells of an important protein, these lead to nerve cell death. It's a series of steps down, and the ultimate thing is nerve cell death, which is often mediated by free radicals. So that the initial thoughts for genetically caused degenerative disorders is if you soak up free radicals with antioxidants, you should be able to protect the nerves and slow progression. Works in a test tube, probably has some impact on the animal models, but I think by the time all those dominoes fall over and you get to the free radical stress that's targeting the nerve cells in the balance center, it's going to be harder to stabilize and reverse that with simple antioxidants. But simple antioxidants do have other benefits. People will say their energy levels are better. Cramping may be improved. So most antioxidants are safe to try. And if you want to try one, give it at least 3 months to show any benefits it might have. Now, Susie has been diagnosed with SCAR10, which is a recessive ataxia, and the classifications of, and I presume this is SCAR, not SCA, the recessive ataxias have 2 or 3 different classification systems, as opposed to the dominant ataxias, which are SCA1, they're up to SCA50 now. With the recessive ataxias, different groups have classified them in different ways, and there's now an international attempt to make sure that we're all calling them the same thing and keeping track of them in the same way to improve our ability to develop treatments. So with this diagnosis, when walking and taking a rest, after resting, telling my brain to walk forward, I end up walking backwards in a circle. Okay, so 2 things can happen with walking or resting, or walking and then resting. Walking can fatigue a person. Resting may restore them. Walking can, you can be slower, you can be more shaky, you rest for a period of time, you can get up and move on, relatively closer to your baseline. Now here, an individual is saying that after resting, it seems, trying to get the signal to walk forward ends up walking backwards in a circle. So sometimes resting could cause muscles to stiffen up, in which case you'll stand and you'll try to walk and you're just slow and draggy, and then ultimately the stiffness goes away and you can resume walking at your normal pace. The tendency to walk backwards comes from basal ganglia connections, which communicate with the cerebellum. So that in this case, there may be, besides cerebellar involvement, basal ganglia involvement. And after resting, the cerebellum may take a little longer to kick in. The basal ganglia dysfunction manifests first by having you, veer backwards or walk backwards. So it's an interesting phenomenon, and I hope your neurologist has discussed it with you and examined you to try to explain it better. Sometimes, that problem, whether it's a stiffness or veering backwards, after resting. If you get up, you stand and stabilize, you can usually then move forward in the proper direction, after, your upright stability has reorganized itself. Now, Miwa has a SCA, type unknown, and Hashimoto's disease. Do I think Hashimoto's disease can cause ataxia? Yes. Hashimoto's disease is an autoimmune disease of the thyroid gland that ultimately results in decreased thyroid hormone. There are some thyroid disorders where, there's an antibody that, increases activity of the thyroid and you get too much thyroid hormone being produced. But the end result of Hashimoto's is you need to usually take thyroid hormone replacement. If your thyroid hormone levels are low, that does increase your risk of ataxia. So one of the tests that's done in somebody with an unknown family history and a balance problem, you check vitamin levels, you check thyroid levels to make sure, and B12 is another common one that can cause balance problems in an older person. Now, just because you have Hashimoto's doesn't mean that you don't have a genetic factor as well. One does not exclude the other. So I think given the fact that we're discovering newer ataxia genes all the time, and in the last couple of years, in a population of people over the age of 50, we have found the RFC1 canvas gene, which is recessive cause of ataxia. And we've also isolated SCA27B, which again is a dominantly inherited late onset ataxia. So be sure to keep up with your genetic testing and general health. Now, Donna says, husband was diagnosed with an autoimmune-related cerebellar ataxia 3 years ago. And with that diagnosis, there are a variety of treatments that can be offered to, reduce the immune system impact on the cerebellum. Things like steroids, things like intravenous immunoglobulin, IVIG, things like plasmapheresis, or even immunosuppressant agents of the type that might be used in cancer treatment, for instance. And, since the diagnosis of the autoimmune-related cerebellar ataxia has developed smoldering myeloma and cardiac amyloid. Yes, these conditions could be related. Myeloma does cause the production of clusters of bad antibodies, which could have an impact on neural functioning. Now, the cardiac amyloid is an unusual factor, and I would again have to look that up. I am not sure. The amyloid protein that is building up in the heart is not an immune system protein. It's a different protein. So I'm going to check its relationship to myeloma to see if there is some connection, but I hope your husband's doctors have addressed this question with you as well. Francis, will research happen on regeneration of Purkinje cells? Absolutely. The idea that we can do neural restoration, in whether it's with a stroke or a brain injury where there's missing groups of nerve cells, work has been going on for years in spinal cord injury as well, using stem cells or nerve growth factors to try to stimulate those damaged nerve areas to repopulate, to regrow, to reconnect. Now, with cerebellar disorders, you're right, there's a loss of Purkinje cells. Ultimately, the cerebellum, becomes smaller. Could we effectively regenerate Purkinje cells? It's possible. I think it's more likely that you could stimulate Purkinje cells that are still there to take over some of the pathways that have been orphaned by Purkinje cells that died, that are no longer there. But at some point, if you've lost too many Purkinje cells, there may not be enough foot soldiers waiting in the wings to come in and take over. Restoring nerve cells with stem cell transplants or other neural cell transplants has been done or tried and is still in trials for spinal cord injury and Parkinson's disease or basal ganglia mediated disorders, because those are small, compact areas where theoretically you could put in your new cells and they would, turn into whatever cells they were supposed to do and reconnect properly. Now, the cerebellum is a very large organ with, multiple layers of cells that work together, as well as the Purkinje cell layer. So, to reliably regenerate Purkinje cells, not that it couldn't be done, but I think we might have more success with something like nerve growth factors, taking advantage of the remaining Purkinje cells, or our own intrinsic stem cells that we have sitting in our brain that haven't yet developed, to let them grow in a natural way. And you can see the hand waving that's going on, because this is very much at the frontiers of neurologic research. Now, Matt says, does work done with proteins by today's Nobel Prize winners, I saw that, have any ramifications for SCA research? Absolutely. This was the work with microRNA, I believe you're referring to, unless there were some other winners as well. And we know that the microRNAs, small pieces of RNA material, can influence the DNA, can influence DNA processes, and can influence RNA processes on their way to hopefully make proteins. And we know that DNA, RNA, protein production is altered in spinocerebellar ataxia and potentially in some of the other ataxias. So it's possible, learning to use microRNAs better will give us more tools to develop drugs in the pipeline. Tracy has a question. Can I please update on newly approved drug? The only newly approved drug that I'm aware of for any of the ataxias, okay, I take that back, there's two of them. One is, Skyclarys or omaveloxolone for Friedreich's ataxia, which could absolutely have application in any other neurogenetic or neurodegenerative disorder that compromises the mitochondria. You can improve energy production, and that would flow over into improving whatever nerve pathway was involved. Now, there was recent publication of work with acetyleucine, which had a study done, the IntraBio study, for some rare causes of ataxia, ataxia telangiectasia, late onset Tay-Sachs disease, and Niemann-Pick type C. And it was recently approved for Niemann-Pick type C, which is, a metabolic disorder, recessively inherited, that, alters the production of an important protein. And the acetyleucine seems to improve performance in those nerve pathways that are deprived of their normal protein mechanism. So that's about as much as I know about that. Niemann-Pick C is quite rare, at least in my clinic. I've seen maybe 2 cases in adults over, my entire practice. And certainly if it were approved for somebody with Niemann-Pick type C, I would want to try it immediately to see if it would be beneficial. Do we think it could be beneficial for other forms of ataxia? Like I say, the study included ataxia telangiectasia, which is a childhood ataxia, and late onset Tay-Sachs disease, which is a disease of late teens and early adulthood. The results were not as dramatically helpful in those 2 disorders, but if this drug is available, absolutely worth trying, if you can get it, reasonably, and monitor yourself over, 3 to 6 months to see what benefits there might be. Can I explain Perrault syndrome with cerebellum ataxia? I have not heard of Perrault syndrome, and it's another thing I'm going to look up. So we'll get back to Dan about that. And certainly if you're asking a question and you have some additional knowledge about it, that the average doctor may not know, include it in your question, and that'll help orient me a little bit. Now, Jane has a question. Could lamotrigine provide any relief for balance issues associated with SCA3? The neurologist that Jane is seeing prescribed it starting at a low dose and then ramping up. Now, Lamictal or lamotrigine is an anti-seizure drug. So it stabilizes electrical pathways that are involved in generating seizures. Many seizure medications can be used for tremor. They stabilize. I don't know about, any neuroprotective effects of lamotrigine, but, when I have used drugs in that family, it's usually for tremor. And if that's what they're trying, then potentially, and SCA3 can have tremor. I'm not sure what impact it would have on balance unless there was a tremor associated with the balance issue. Anne has a question about temperature sensitivity and ankle swelling. So first of all, with ataxia, ankle swelling can be pretty common because you're not as mobile. And the more you sit, even sitting in an office all day, by the end of the day, your ankles will be swelling because, blood flows down, our muscle activity helps pump it back. If we're sitting and not using our muscles, our ankles and feet tend to get a little puffy. On the other hand, if we have problems with circulation, varicose veins, or other circulatory issues, that can predispose to ankle swelling. Certain medications can predispose to ankle swelling. So if you're developing new ankle swelling, be sure to check, the many things that could be causing it, because many of them are reversible or treatable. Now, temperature sensitivity is felt to be connected to the autonomic nervous system. We have, temperature monitors in our brainstem. We have peripheral nerves that respond to, environmental heat, environmental coldness. People who, have hormone changes may become more sensitive to temperature changes. If your thyroid balance isn't correct, you may be cold all the time. You may be hot all the time. So if you're noticing temperature sensitivity, again, think about other things that could be causing it. If, however, your ataxia is associated not just with cerebellar involvement, but peripheral nerve involvement, that could predispose you to temperature sensitivity because those peripheral nerves control peripheral circulation, and you may be not handling temperature, environmental temperature, positively. So number one, make sure there isn't something else contributing to this. Number two, if you find that you're cold sensitive, stay warm. If you find that you're heat sensitive, try not to get overheated and be sure to stay hydrated, and to protect yourself that way. Sometimes temperature sensitivity can interfere with sleep. You're trying to sleep, you're too hot. You're trying to sleep, you're always cold. Your feet are cold. And again, you treat it, symptomatically as best you can by altering your environment. Now, Eugene has a question about using troriluzole with canvas, which is one of the newly discovered genes, RFC1. It's recessive, and results in, as the eponym suggests, cerebellar ataxia, neuropathy, vestibular atony syndrome. So that people develop ataxia, they develop a peripheral neuropathy, and they develop vestibular changes that can lead to pretty bothersome dizziness. Some people have all three, some people have only neuropathy. And the studies being done in Europe are collecting groups of patients that have just neuropathy, just ataxia, just the dizziness, or some combination of those three. So theoretically, with the cerebellar component, troriluzole, from what we know about its mechanism, could be helpful. If, however, you only have the neuropathy or you have the dizziness, troriluzole may not be helpful, and troriluzole may have a side effect of dizziness, so that's something to be alert of. And Barbara has a similar question about use of troriluzole. And I would say if you have significant dizziness, use troriluzole very carefully if you can get it. But for the ataxia, I think it is definitely worth trying. And then Sherry also has a question, I presume, about troriluzole. Can we get compassionate care use of it? Currently, the official studies of troriluzole in spinocerebellar ataxia have finished, and people are slowly being transitioned to a compassionate access program or an expanded access program, which is not just for people who were involved in the original studies, but people who also have ataxia type 1, 2, 3, 6, 7, 8, or 10, and weren't part of the study, but because they have a diagnosis that was part of the study, they can now have a study doctor near them apply for admission to the compassionate care program. Canvas, however, is not part of that study. It would be difficult to get compassionate access to troriluzole in its current state until we know how the FDA is going to handle it. But regular riluzole could absolutely be tried. But again, remember, could help with the ataxia, but probably could make dizziness worse if that's part of your Canvas syndrome. Now, Rhonda mentions, SCA6, balance and speech are bad, midline cerebellar functions. What medications can help? So with my SCA6 patients, ones that were in the troriluzole study, ones that weren't part of the study, I use riluzole, I use dalfampridine. One or the other may be helpful for balance or speech. If tremor is involved, compromising balance and speech, which it could be, there are many drugs that are used for tremor that could help settle that down and improve performance. So this is something you're going to want to discuss with your local neurologist. It may be a trial and error. There's lots of options, and you may end up trying 3 or 4 until you find one that works for you. Rita has an interesting question. How has the development of glaucoma been associated with ataxia? I am not aware that glaucoma in its traditional form is part of any ataxic syndromes, although I'm sure if we, Googled or, asked ataxia and glaucoma, some rare genetic syndrome would come up. There are other eye-related difficulties that can be associated with ataxia more commonly, besides just incoordination of eye movements and the double vision or dizziness they may cause. Some people have vision loss because the nerve that controls vision, the optic nerve, may also become involved with their particular type of ataxia. But glaucoma, I think, is much more common as an unrelated but very prevalent condition in the community and has very good treatments available. But I will check on that. Alicia has a question. What vitamin or mineral is recommended for ataxia? Now, as we said, when we suspect that there are free radicals being produced by the stress, the genetic stress, or other stress leading to the ataxia, you think, well, an antioxidant vitamin should be helpful, an anti-aging vitamin. We know that many of the genetic ataxias in particular, you've been born with the gene, but the symptoms don't appear until what we know about aging begins to kick in, usually in your 30s or 40s. So it would make sense that any anti-aging vitamin or vitamin mineral combo that has some track record in aging research, and there's a lot of stuff out there that's snake oil that may or may not be helpful. I myself decided it would be a great idea if I started taking omega fish oil and chondroitin to help with joint issues. So I started taking both at the same time, got itchy, gave up because I wouldn't know which one was the problem, but decided I would just muddle along without them. So I think if you're going to be starting an anti-aging supplement, which would be the ones that I would think would have the most importance for the types of ataxia that we see in adults, vitamin E, CoQ10, the omega fish oil has a track record. Those are the 3 that seem to have some impact on aging-related mechanisms that could be tempered a bit and might have an impact on ataxia. Now, on the other hand, certain symptoms in ataxia, muscle cramping, could respond to magnesium. So think about your symptoms. Talk to your doctor that you see about a natural remedy that might be helpful just for symptom management. Now, Rita says she has SCA2 and experiencing tingling and some numbness in her feet. There is a neuropathy that is associated with SCA2. Is that likely ataxia, or could it be some other cause? It could absolutely be some other cause. SCA2 is known to have a neuropathy, but there are many, many other causes of neuropathy, diabetes being one of them, circulation problems being another. So if you begin to notice tingling and numbness, Your neurologist can order an electrical nerve and muscle test to see, is it the little nerves, is it the bigger nerves that could be causing that, as well as an evaluation for, vitamin deficiencies, diabetes, and a check of your circulation. Now, Laddie, is again asking about troriliazole. So indicates that from the published results that we've all seen in the press releases, if you start taking it, you don't get better, you just don't get worse as fast. In what we've seen, and again, they did kind of a staged analysis. The original study, with the placebo versus real drug, didn't show statistically significant improvement, but did show decreased falling, especially in the SCA3 group. Now, that wasn't enough to push it across the finish line with the FDA, but the FDA, wanted additional analyses done on everybody who was in, all the studies of troriliazole that were done. And with the additional analyses, they did show a statistically significant improvement in symptoms and over time, slowing of progression. So I think with better analyses, better living through statistics, they should be able to show the FDA that there is a measurable benefit, not just by the numbers, but that people actually say they feel better on it. And certainly even with regular riluzole, I do have people who start taking it and they can immediately say tremor is better, speech is better. So I'm hoping that the FDA, when they look at this final set of data analyses, will take into account and approve the drug with some indication of what it's best used for. And I hope it gets a more general indication. Now, Jean has a question. Can amantadine help balance in SCA27B, and can it be used with dalfampridine? So they're chemically different in what they do. Amantadine stimulates monoamine pathways, serotonin, adrenaline, dopamine, which we know can have a positive impact on cerebellar functioning. Those are some of the neurotransmitters that are important for the cerebellum and its communication, outside of the cerebellum. Now, dalfampridine, as we said, works on stabilizing the electrical pathways that have to work in proper coordination. So their targets are different. Side effect profiles are very different. And I would feel they could be used in combination. And the best way to look that up, and this I think I will look up right now, you look up drug interactions, Google drug interactions. There are a couple of websites devoted to that where you type in one drug, and we'll type in dalfampridine, and you type in the other drug, amantadine, just because they both end in dine. You wonder maybe there is some interaction, and it says no interactions. So I think we are okay in that regard. And because their mechanisms of action are different, you might get some additive benefit, for any cerebellar disorder, not just SCA27B. Now, Sean has a question, all too common, Sean feels. Answer dependent on a number of fluctuating variables. You took the words right out of my mouth. Best guess as to the timeline as to when any of the gene editing therapeutics under development might reach the approved publicly available stage. So if there are gene editing techniques that are ready to get into human trials, and that's a big ditch that you have to cross to finally get into human trials. And as far as I know, there are 2 companies working on splicing mechanisms, which don't change the gene, but they can edit the messenger RNA that the gene is producing, which can then allow more normal protein production. So we're kind of at a point where there may be some early human trials, phase 1, going in this general group of gene editing therapeutics. So if your regulatory agency is willing to give you a conditional approval based on biomarkers that you can edit the gene, edit the messenger RNA, and show that you're producing more functional protein. Sometimes the FDA will say, okay, we'll approve it because it has very few side effects. The biomarkers that we're tracking look good. But the conditional part is that after it's been out in broader use, if it's not really showing improvement, it might be withdrawn from the market. And that happened to one of the drugs, either for ALS or Alzheimer's disease, that was approved on the basis of biomarkers, but after it was out there and in use, didn't really show the benefits you would want to see. So a typical timeline from a phase 1 study to approval of a drug has been as long as 10 or 15 years. But with better measures, better cooperation of regulatory agencies, and the possibility you could get a conditional approval, potentially you could see something approved and at least conditionally available in as little as 5 years, which can be a long time for any progressive disorder. So we're all tracking the pipelines that the National Ataxia Foundation has online to hopefully keep up with these important areas of drug development. But that was an excellent, cautious way to pose your question, Sean, and I'm glad we could discuss that. Now, Sherry has a question. Anything to help with downbeat nystagmus that isn't a drug that affects balance? Ooh. Dalfampridine is noted to help with downbeat nystagmus, and its side effects don't make your balance worse, as opposed to riluzole or troriluzole, which may or may not have an impact on nystagmus and could make your balance worse if it makes you dizzy. So I think if you have downbeat nystagmus, dalfampridine is worth a trial. Baclofen has been used for nystagmus, but it could make your balance a little worse or could make you feel weak. So, and there are, many other drugs that, are in the National Ataxia Foundation list of drugs for symptoms of ataxia that, are reported to be helpful for nystagmus. But I think the one for downbeat nystagmus that most of us are convinced, is worth a trial of dalfampridine. Now, Alicia has a question. Any suggestions for shortness of breath while sleeping? Will this be a likely cause of death? Wow. Shortness of breath while sleeping most commonly relates to sleep apnea, where when you fall asleep, your breathing center is going to automatically stay active and control your respirations. And in various neurogenetic disorders, including the ataxias, if your coordination is off, the coordination of breathing during sleep could be off, so that you'll have obstruction, the muscles should open and they're not opening properly, and you end up not being able to breathe deeply, and it wakes you up and you feel short of breath. On the other hand, there'll be other causes of shortness of breath while sleeping. If you have allergies and you get nasal congestion while you're sleeping, you wake up feeling like you can't breathe. So I think, you need to, number one, discuss this with your primary care doctor or neurologist. If you think you could be having either an obstructive sleep apnea or sometimes a central sleep apnea where the breathing control center in the brainstem is defective and not controlling breathing properly. A sleep study will show this, and there are various treatments that are available. And if left untreatment, number one, your sleep is going to be disrupted. You're going to be exhausted the next day because you haven't had refreshing, restorative sleep. Number two, if it's obstructive sleep apnea, it does put pressure on the heart and lungs, and could contribute to heart or breathing problems. Could potentially cause stopping of breathing during the night, which could obviously be a cause of death. So it's a symptom that needs to be followed up on. Anna Maria, do you have to be genetically tested for troriluzole? We don't know. Currently, the Expanded Access Compassionate Program requires a genetic diagnosis. I don't know if the Compassionate Program is asking to see genetic testing results, but it's left to the prescribing doctor to confirm, at least for now, that a genetic diagnosis is required, even though it could potentially be useful for other non-genetic ataxias, possibly. Henning Bude had been a participant in a clinical trial at a university hospital. The hospital stay was then billed to his health insurance. Is it unfair that I have to apply for third-party funding and let others pay the health insurance companies? So if this was in the United States, that's really unusual. There are some research trials that are tacked onto a hospital admission for the underlying problem. Somebody's already in the hospital for a stroke or a heart problem, and somebody's doing research, and they can tack on their clinical trial to that hospital admission. And they say in the consent form that, you know, standard of care stuff will be billed to your insurance. Anything that's research will not be billed to your insurance. So if it is truly just a clinical trial that is funded, you know, a properly done clinical trial, and that's the only reason you're going to be, you know, seen in a hospital setting, at least according to ethical standards in the United States, people should not be billed for that. And if for some reason, you know, you have to bill them, they have to be told up front that your insurance will be billed, and that they have the opportunity to not participate. But you're right, it's a terrible, you know, it's a terrible decision to force somebody to have to make for a promising trial that they would have to shell out for. It's kind of like going to, you know, Central America for stem cell treatments, you know, where you have to mortgage the house to pay for them, you know, with no guarantee that it's going to work because it's research. So we try in the United States to not bill for things that are purely research. And if there is a component that has to be billed for, that it is fully explained in the informed consent form. Now, Sean has a question. Canada has a regrettable record of approving rare disease therapeutics that have been approved in the US. Canada has to date approved only 60% of such therapeutics. I remember when idebenone was under study for Friedreich's ataxia, and it didn't appear to be meeting its endpoints for approval by our FDA, but Canada did give conditional approval to it, which was unusual. But you're right, it's usually reversed. And we're seeing now with, you know, Skyclarys or omaveloxolone for Friedreich's that, you know, the United Kingdom, Canada, you know, New Zealand and Australia are foot dragging on, you know, looking at the data and getting it approved in those countries. So I think some of the concern may just be on a purely scientific basis. They want to look over the data themselves. They want more, you know, information about real world use in countries that have approved it. Are there any unexpected side effects that might alter whether they're going to make it available to their citizens? On the other hand, it could relate to the insurance support, that any new drug for a rare disease is going to be expensive. You know, companies can have patient assistance programs, but you know, if the insurance, you know, and in these, you know, countries where there's, you know, kind of, you know, centralized government related insurance, they may want to, you know, fully examine the cost that will be incurred to decide if and when they will approve it. So a little bit of the insurance politics there. Oh, and then newest drugs for MSA. There's 5 that are in clinical trials. All of them target the abnormal protein that's building up. All of them have had excellent data in animal studies, and we're hoping that in the next couple of years, one of them will cross the finish line and be approved for that very difficult non-genetic disorder. This has been terrific. I could go on and on. Great questions. I've got my homework here of things
Yes,
that I'm going to follow up on, Lori, so I promise to
me
get back to
too.
you about that.
Just another session of excellent questions and expert responses as usual. But thank you everyone who's joined today and for your excellent questions. This was another amazing session. And thank you, Dr. Perlman. Take care, everyone.
Bye-bye.